So you have this is the neck. You have a homur and inferiorly. So your neck is between the two homurs. You are quite safe there. Then I can take the head out and measure the head diameter at this side. So I know if it is 48, then my cup is either 50 or 52. If it is 50, I always either go for 2 millimeter, 4 millimeter, 6 millimeter. Unless it's very subluxated, then it's a different. Most of the templating is on the head itself. The retractor, the soft tissue retractor, and the woman's. And cup is exposed and you start reaming. Regular reaming is sequential reaming. Go to the medial side, always there's a tendency to take the anterior wall off. If you're not careful, because you ream straight across on the horizontal plane, you take the anterior wall off. So they always go a little bit posterior and more medial. Try to be always towards the ligament of varus, TFL. That's the prepared acetabulum. I just want to show you you can see the ligament of TFL very clearly. Sorry. Can you see the TFL? It's actually all parts of the acetabulum 360 degrees can be well visualized after the preparation. So after this compensation is technically much easier. The cup, as I mentioned to you, the mouth is smaller, inside you have more space. So you have to introduce the cup in an angle where it will go, and inside you have a lot of space. So tilt your cup, and most of the companies have an angle introducer. So you attach the introducer in the inside, and then position the cup as you want it. And the first few, obviously, we would like to have a image inspired. Cup is in. Trial, I think that's a trial. Then. And you can never retrovert the cup on this approach because the femur is in front of you. It will never allow the handle of the coupling introducer to come down. So you cannot retrovert. The only mistake you will do is you will antivert the cup too much. So, and the only, if at all, if it dislocates, it will only dislocate anteriorly. So you cannot retrovert the cup. It's very, very difficult to retrovert the cup. So try to keep the handle as parallel or about 5 to 10 degrees, and that is cup in place. Then we go for the femur. Again, about 10-20 degree extension of the leg. And we don't have to hold it, but sometimes you may have to adapt it or externally rotate depending on it's only to prevent the handle of the impactor. Those retractors are not elevating the femur. You can actually I used to keep a Ethibond suture on the capsule. You can pull the Ethibond suture, and the femur will lift up to the wound. So it is not the retractors are bringing the femur. There is a fear in this approach. The femur is at risk. The femur is never at risk if you do the release. do all the steps. That's I'm basically reading the Palka read method. You have to negotiate a little bit because most of these instruments are not. You can go in, then you have a lot of space. At the mouth you have very restricted space. He's a male patient, so this patient better brother. I just want to show the leg position. Yeah, so that's the leg position when I'm preparing the femur. So it just lies there, and you can drop the leg, the foot end of the table accordingly until your thumb, and the handle is not touching the skin. Now there are devices that it will hold your retractor, so you don't need two assistants to do this operation. It's actually another patient, but you can see how well you can clearly see. I don't think there is any restriction on the femur. You can see 360 of the femur as well, and there is no other structure is taken off except the piriform fossa is empty. There is no other posterior structures are removed. You can usually put the femoral stem with your hand, then the last bit you just have to use the curved to introduce the protection. I keep the capsule as that protects me from battering the TFL. So I keep the capsule. It's not because for stability. I don't repair the capsule. I just put one stitch at the end of the operation. Sorry. No, you cannot do this with any other approach. This is the only approach you can check your leg length this way. And you can flex, check, you can do all manipulations to check your stability. And relocation is very easy. It's not, don't struggle any part of any way during this operation. And if you are struggling, then your release is not good enough. I do inject the periarticulous tissue with the local anesthetic and adrenaline. one capsular stitch for the both flaps with the Epicon. And that is the status of the tissue after the thing. It's actually another patient on the left side. I don't have the video for the other one, but you can see the tissues. That is the fascial covering of the TFL. It is not lacerated. It is not battered. And the lateral cutaneous thigh is actually on the medial flap. That's the suture tissue. And suturing of the wound is very quick, so you only have to suture the fuse on the TFL fascial covering, and there's no other closure. That's the skin fixation again. That's so he is driving from 6 days after the surgery. Thank you. That's most of it. No, finish. Thank you. I strongly believe this is a reproducible approach, and it just can be applied, and it's much safer approach than any other approaches.
I thank you.